My name is Lowell Kadnick, and along with Victor Kanata, we welcome you to Veins and Lymphatic University Grand Rounds, featuring important topics through case discussions. Grand Rounds will occur every Wednesday from 12 to 12:30. You can tune into Zoom or YouTube. Our featured speaker today is Professor Bozkurt from Turkey, who will talk about cyanoacrylate and perforators. This will be followed by our discussants, Misaki Kiguchi from the United States, Nicolas Neaume from France, and Imre Bihari from Hungary. To our guests, please use the chat box to post questions. Kürşat, the floor is yours.
Thank you. Thanks a lot, Lowell. Right. Can you see my slides? Everything is good?
Yes.
First of all, glue is some sort of mysterious stuff, and people are quite often ask me for which patients you use routinely. Definitely, if the patient wants it below 12 millimeters, allow glue for below knee saphenous vein, for distal short saphenous vein, and definitely anti-inflammatory perforating vein ablation. I'm going to show you some patients for it one, for redo cases, and for long stump after surgery or thermal ablation. There are two popular glues in the world now. One of them is Turkish one, the other one is American one. Both works very well. There's no big difference at all. There is one important difference in terms of perforating treatment is Turkish glue has very short polymerization time, which is 5 seconds, only 5 seconds. Instead, American glue has a polymerization time of 20 to 30 seconds. That might be a problem because you may end up with some sort of embola in the deep system if the polymerization time is long. There are some other differences, but I mean, it's not very important, though both of them works very well. And what we did is we recently did a meta-analysis in comparison to glues. And as you can see here, in terms of closure rates, in terms of quality of life data, there's no big difference at all. And all works very nice. And in comparison to thermal ablation techniques, works very nice. Although I have to admit, still in my practice, thermal techniques has priority. And in some patients, in some good selected cases, I like to use glue ablation. We have now good data, 5 years data with American glue, the over 90% closure rates. And in Turkish data, we also have very good closure rates, over 90% for different glues. Another one, 8 years follow-up, it shows very good results. And another 5 years data, which also has very good results. We have been using glue for different circumstances. This is one of the patients with advanced disease, and we can use the glue in all cases. As you can see, it's a very strong thing. You can't liberate your fingers when you are putting even one drop of glue after some time. And that's why in all guidelines, which is our guideline, which we published in 2020, we recommend that glue 2AA. And for European guideline, it's 2AA again. And American guideline also very strong data, which is good for the glue ablation. Professor Kadnick loves me to show this video because it's not my patient, but we should be very careful when using glue. It's a procedure. Unfortunately, they did put the tip of the catheter in the deep vein, and the patient ended up with the glue in the deep vein. This is only one patient I've seen in my practice, this kind of patients. And this is not a correlated endarterectomy. This is glue endarterectomy. What I'm saying is we should be very careful when using glue as the other techniques. Definitely, it's very important. If we talk about most for perforating vein ablation, actually, this is not perforating vein ablation. This is a long stop after surgery. As you can see, we can just put a glue in the saphenofemoral junction, and for the rest, we can do foam ablation. This is another patient with Klippel syndrome. You will see big channels here. Foam doesn't work here in many patients, but you can easily block these big channels in Klippel syndrome with glue ablation. And we do a procedure like that, foam and laser plus glue in these legs. We do like total abla, but this is not a normal patient. This is a Klippel patient. Regarding perforating vein ablation, last week I operated 2 patients with very big, very dominant perforating vein. This young boy is 17 years old, 17, only 17, and he had one varicose vein surgery in another country. Believe me or not, but this is a stripping procedure, and these incisions are after stripping. As you can see, there's a terrible incisions for stripping. This young gentleman had a bony stripping procedure with standard surgical pressure. But in reality, the main problem of this young gentleman was a huge, big perforating vein. The size of the perforating vein in this particular case was 1 centimeter. It's a huge perforating vein. It was going upwards. And this young gentleman have C5 disease. What we did here is we used Turkish glue. Usually 0.8, 1 mils is enough for a big channel like that. We do direct injection with 18 gauge needle to the perforating vein. You can see here the needle. This is the needle just in the fascial level. So what I am suggesting is the tip of the catheter should be, maybe you can see here, just on the fascial level. It's enough. If you are very superficial, the patient may feel a strong stuff there. It's not good for them. They don't like it. But if you are very deep, you may block the deep vein. So just fascial level is enough for this procedure. And many people are asking me, Dr. Bozkurt, how do you control deep system? If you are using Turkish glue, you can just simply inject there with blocking the tip of the catheter with your finger. The polymerization time is only 5 seconds, and it works very nicely without problem. And soon after that, I'm pressing for 1-2 seconds to the perforating vein. And as you can see on the right side, glue blocks this big perforating vein very nicely. You can easily see in these slides the blockage very good. So the glue ablation for perforating system, it works perfectly. In other patients, actually, I operated this patient several years ago. It's going to show a complete procedure with using radiofrequency, glue ablation for perforating vein, and also foam. I operated this lady 15 years ago with radiofrequency ablation, and unfortunately, we had recurrences on both sides. In the saphenofemoral junction, you can see here, it's my patient. Nobody did it. It's my patient. And there's a big perforating vein in this particular patient. The decision is doing thermal ablation for the proximal parts. The question might be, Kürşat, why you didn't do glue ablation here? I can do, but it was really big saphenofemoral junction, something like 18 millimeters. That's why I wanted to be in the safe side. I just did radiofrequency ablation for the proximal part. And for the distal part, again, I did a cannulation to the perforating vein with this time 18 gauge needle. And the catheter is there, and I am here. So after that, I'm again using the Turkish glue here, 0.8, something like that, and injecting direct there with finger palm control of the proximal side. Calculating 0.6 effect. Don't worry, it's going to stay
Tamam zaten.
on the square. This patient was a 80 years old lady. We are doing all of the procedures under full local anesthesia. And when injecting the glue, she felt some sort of pain, but it was very bad though. And the closure of the perforating vein is after the procedure. Then we turn to the proximal part and we did radiofrequency ablation for the proximal part of the vein because it was really a big vein. And finally, we did foam ablation for the distal part because this patient already have had a recurrence after my initial procedure. I didn't want any more problem. And for the rest of the lower part of the distal saphenous vein, I just did foam ablation. And with a standard tesseract method, we did a foam ablation and we finished the procedure. Dr. Lovell Kaepernick asked me to shorten my presentation to 12 minutes, and it's exactly 12 minutes now. And thanks for listening to me. This is my dog. She's 4 years old. And although sometimes problematic, I can't survive without her. Thank you.
Thank you, Kürşat. That was well done. I really appreciate it. I do have one question before I turn it over to the discussants, maybe two. One is when you press on your cyanoacrylate in the perforator, how come it's not going into the deep system if you're at the fascial level?
If you are slow, like I did, and if you are away from the deep system, usually there is a gap between 0.5 mils between the tip of the catheter and the real deep system. So there is no time for going there. But you can't do that with American glue. It's very crucial here. So this is one big advantage of Turkish glue. By the way, I did maybe 200 cases until now. I haven't seen any deep vein thrombosis because of the glue.
The second question is, how do you know how much glue to insert?
Definitely not less than 0.5. Definitely not less than 0.5. Definitely not more than 1 mils. So something between 0.5 and 1 mil. I cannot tell you if the size is 0.5, this one, 0.8 is this one, but usually 0.7, 0.8 is enough for closure.
What do you look for,
say again?
Kürşat? What do you look for?
The size.
Okay.
For example, in this patient, the perforating went really big, and I put 1 mils. But for an ordinary normal 6 millimeters perforating vein, I usually do 0.6, something like that. But something between 0.5 and 1 mils.
Thank you very much. Misaki, floor is yours.
Thank you very much, Dr. Bozkurt. I think when you started the conversation here, you did discuss sort of who is the ideal patient for this. And from your presentation, it seems like many of these ideal patients are patients who have maybe recanalized or have just sort of symptoms right at the perforating veins. Is that sort of who you use these direct punctures on? Just for patients who have symptoms coming from these large perforators? Because in my practice, I often, even if I do see perforators, obviously I get rid of their axial veins first, and then most of the times they feel better. And I am very interested in sort of gluing these perforators for these patients who, in reality, they may not necessarily have a lot of axial reflux, but it's just these painful varicosities coming off of one perforator. Do you think when you started off the presentation of who are the ideal patients, that would be a good summary of who you would use this on?
First of all, I totally agree with you. We have a lot of discussions about this issue as well. Perforating vein ablation should be reserved on a limited, selected, well-selected, a small number of patients. definitely, even the patients might have perforating reflux. We should, first of all, do truncal ablation for the superior part. What I'm doing is, for example, if the patient has a big venous ulcer, and if the patient doesn't want anymore, struggling with this kind of things, sometimes even at the beginning, and if the size of the perforating vein is big, for example, let's consider C5, C6 patients, I may do truncal ablation plus perforating vein ablation in the same session. But for ordinary cases, for example, up to C4 patients, there's no ulcer, there's nothing there. First, I do truncal ablation, wait for a long time, sometimes 3 months, sometimes 6 months. If there's a problem, yes, after that, I do perforating vein gluteal ablation. My priority is truncal ablation, then, if necessary, perforating vein.
Absolutely. It's what's interesting is I deal with primarily CEAP6 patients, and I do use cyanoacrylate quite a lot, but I have noticed too that when I go to ablate the entire calf portion, especially where a lot of these perforators are, and I pay attention to these areas of perforating veins, and I squeeze a little bit extra in there and kind of milk it in. I do see that a lot of these perforators on post-op duplex do close off, but I think you're absolutely right that you try to get as much bang for your buck at each procedure, especially in these patients with advanced disease. And really paying attention to these perforators, I think, will really do wonders for the healing process.
Thank you, Misaki. One quick question from the audience. They wanted to know if you use any prophylaxis when you do perforators.
Actually not. I mean, in my praxis, I do prophylaxis on selected patients. For example, if the patient has a thrombophilia, like factor V Leiden mutation, something like that, if the patient has a previous history of DVT or some sort of superficial phlebitis, I do thrombophylaxis for these patients. But for the rest, it's not in our routine to the routine prophylaxis. I know you may criticize me if, as you are working in United States, in Europe, with a big medical legal issues, something like that. But in my routine practice, even for perforating vein ablation with glue, it's not my routine to use prophylaxis for all patients.
Thank you, Kürşat. Thank you, Cecilia, for that question. I'm now going to shift to Nicolas. The floor is yours.
Okay, thank you. Thank you, Kürşat, for this topic. Very interesting. Perhaps, as you know, I use American glue in France in my practice, and I treat also perforator. But for treat perforator, I fit my syringe into the gun, okay, and I do direct puncture with my needle, okay. My question is about your catheter. Into the catheter, you have a reflux of the blood, okay? And I've used sometimes polymerization of the glue into the catheter. Because me with the needle, we don't have this polymerization. You understand what I mean?
With metallic needle, you mean, Nicolas?
Yes.
With
yes.
metallic needle, you are not seeing polymerization, huh?
Yes, never. But you, in the catheter, this is plastic, no? In this plastic,
Yes,
you have the reflux of the blood.
Nicolas, honestly speaking, yes, I've seen some blockage of my catheters. Yes, I did see some, not quite often, but honestly, I never ever tried metallic ones. Maybe I should try. You have a good idea. Yes, it's a good idea. In my practice, I just do a IV catheter, which is usually 18 gauge. It works. But yes, I saw some blockage. I agree. I may try.
Okay, thank you. I have a second question.
Mm-hmm.
You said you treat 200 perforator, yes?
Say again?
You said you have treat 200 perforators.
Yes.
Have you? what is your rate of occlusion at 1 year? This is a good rate of occlusion, or this is repermeabilization?
My closure rate, I had some learning period, and at the beginning for a year, my closure rate was 68%. But in the last 5 years, if I analyze data, I'm going to show this data in VT symposium as well. My closure rates are now over 90%, 90%, which is quite good. I'm not using thermal techniques for perforating vein ablation now, currently, although there are good laser devices, but the closure rate of this device is also around the same. So over 90% is good. I used to do foam ablation for perforating veins, but believe me, it's not good. It's not enough efficiently.
Okay, thank you very much.
Imre?
Yeah, thank you. Thank you for the possibility. And first of all, I'd like to tell you that I congratulate to Kürşat. It was a high-level presentation as usual. And I have learned a lot from Kürşat up to now, but I am doing a little different way than he is doing. So several questions were here, and I'd like to speak about a lot of that. First of all, which was the last question, that the closure rate, our closure rate is about 86%. We did more than 1,000 perforator vein closures. It is more or less a routine intervention for us. If there is a big, very dilated perforator vein, we prefer to use the Tessari technique, which means that we puncture the perforator vein, we give some foam, and as the foam shrinks the perforator vein, after that we inject some glue into the lumen. And if there is a very dilated perforator vein, a little less amount of glue is enough. We use much less amount of glue than Kürşat uses. We use 0.2 or 0.3 ml of glue. We prefer to use Turkish glue because it is available in a separate ampoule, and it is excellent for perforator vein closure. I think it is a little better than the VenaSeal. The main difference is that if the patient is awake, then the patient feels some pain sometimes as we inject the glue into the perforator vein. In the literature, we could find 3 papers which are about perforator vein closure and 6 oral presentations, and more than 600 cases were mentioned in these publications, and there were a minimal complications. So it is very surprising that we are closing the saphenous veins. Sometimes there are immune responses or more serious complications like granuloma or so. But if we close perforator veins, there is no response, no complications. So maybe it will be, but up to this more than 1,000 cases, there were no complications. So maybe the very little amount of glue, maybe that we are doing this in combination with laser surgery, a combination with foam or liquid sclerotherapy, and we are using compression, firm compression. So maybe these are. And one more important thing, that we are using routinely thromboprophylaxis. This is a difference that routinely every patient gets. Because in many cases we don't know what was the factor which promoted the development of a deep venous thrombosis. If we give prophylaxis, I think it is better, but not sure. So when we give some glue, we need to think about this, that a little amount remains within the needle and within the hub of the syringe. So when we give 0.3 ml, then 0.2 will go into the lumen of the vein. So this is what I wanted to tell you, and I hope I could speak about every important questions.
Emery, I have a quick question. Are you talking about Turkish glue? Are you talking?
Yeah.
Okay. I'm going to go back to our people that are using the US glue. Any experience doing perforators with it?
I'm sure it is also suitable. It is necessary to compress.
Emery, I'm asking our people at Nicolas and Misaki.
Yeah, sorry.
Use that glue?
Since it's off IFU here, I tend not to do it. But I have heard of people using the extra glue to definitely do it. And I think especially for patients with advanced disease, I think it's going to be the next step because of how precise it is. And, I think it really works really well. So I do think it should be the next step for sure.
Nicolas?
Yeah, it's the same thing. I use American glue, but only on patients with advanced stage, C6 stage or C5.
So you do use it on perforators and that at C5, C6?
Yes, but only perforators who feeding the ulcer or the trophic trouble.
Kind of squeezing it into the orifice of the perforator. I know that Kathy Gibson, who could not join us, does utilize cyanoacrylate to treat some perforators. And I can't speak for her, but it's kind of interesting to see the polymerization in terms of time and what we feel comfortable with. The prophylaxis in terms of using glue is still debatable. I think even in thermal ablation, it's still debatable. And there was one question more, and I've got to keep it very quick, Kürşat, and that is with Turkish glue, side effects. Are they minimal or are they a lot?
Certain there are some side effects. I've seen some allergic reactions, not too much, maybe 1%. In reality, we haven't seen any granuloma formation with using Turkish glue. Recently, after a paper of Kürşat, we checked again all of the data again and again. We haven't seen any granuloma formation after that. The most common problems we have seen until now is some allergic problems, but nothing more than this.
Pretty much similar with that regard. So I want to switch topics. Next week, June 25th, we'll be seeing something very interesting by Javier Kuluud, and he'll talk about the use of the sausage technique to treat truncal veins through case discussions. Our intended discussants will be Shoa Padira, Tobias Hirsch. And before I leave, Victor, you want to show that little video? I have personally witnessed this procedure, and it is very interesting. So he's got a proximal tourniquet and a distal tourniquet, and he's injecting foam between the two. So with that being said, we will next week see you on the 25th of June at 12 p.m., where Dr. Javier Kuluud will be talking about the sausage technique. Thank you for joining us, and we'll see you next Wednesday on the 25th at 12 p.m.
Thank you.
Thank you.
Bye-bye.
Bye-bye.